Good evening. It is Breast Cancer Awareness Month, and there is a lot to be thankful for, believe it or not. There is new research, there are new treatments, and new screenings. During this next hour, we have physicians answering your questions about updates in breast cancers, and there's a lot of research going on. And again, the treatments have changed so much over the last 5 and 10 years. We're going to talk specifically about what's new in the world of breast cancer treatment, and as you know, this is a live show. So give us a call at 881-0013. We've got 3 medical students with us today from the Paulo Foster School of Medicine, and they are here every month, and they're very helpful with answering the questions. We have his first time here, James. How do you do? James is really great. He came over and he asked, hey, I've never been here before. So James is a medical student 2, second year, and I gave him some grief for just being here the first time. And he says, well, I've been studying this whole time, so I guess that's okay. So Ewan Dang is also here. She's been here a couple of times. She is in her first year, and I guess she's not studying that much because you're here. No, but seriously, we appreciate you all being here. We also want to thank the El Paso County Medical Society because they are sponsoring this show. They have been sponsoring this show now for 22 years. Good evening. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. I love this group of friends that we have with us this evening. I feel like every October, sometimes in September, when we've got a lot of the oncology shows, I get to have this team with us. We have Anu Gupta, who is a radiation oncologist. We have Juan Herrera, who is a hematologist and also specializes in oncology, and Mark Landaros, who is a surgical oncologist. He's a general surgeon, but he does a lot with cancer. So thank you so much for being here. And I always start the show the same because sometimes it's the first time people are watching this show. So, a radiation oncologist, what does that mean?
A radiation oncologist is a specialist who treats patients with radiation therapy with cancer, sometimes non-cancerous conditions. But as a baseline, I'm trained with clinical oncology and specialize in radiation oncology, so I see patients after their biopsies for a consult, discuss options, but eventually if radiation is needed, then I'm the one who supervises the radiation treatment, plans it, defines it, and then eventually follows those patients.
And can I say something on a personal note? I know when I saw you today, I said, hey, I had lunch with an old friend of mine from high school, and I'm not going to say his name, but if I just talk about, oh, well, who is your radiation oncologist? Dr. Gupta, and they have this little smile, and it's like they all have a crush on you. It's so cute, so keep doing what you're doing. I love it. Dr. Juan Herrera might look like he's Latino, but we practice in German when we're counting for the microphones, right? So, oui, and he's speaking French as well. Dr. Herrera is a hematologist oncologist, a medical oncologist. There's a lot of names that kind of go into your title, but what does that mean you do all day, every day?
By training, I'm an internist who has specialized in medical oncology. Medical oncology is the discipline that supervises treatments that are given intravenously or by mouth. So it's the so-called chemotherapy. Chemotherapy can be given through the IV, can be given orally, and sometimes can be given subcutaneously as well.
That I didn't know about. Let's talk a little bit about that tonight too. Okay.
Yes, and the same way as Dr. Gupta as a radiation oncologist or Dr. Landeros as a surgical oncologist, we all take part in the management of cancer from different angles.
And that's what's so beautiful. When I said team, it really is a team, and there's still a lot of other people that play part of this team as well. And Dr. Landeros, as a general surgeon, but also specializing in oncology, feel free to kind of explain to our audience what you do, maybe specifically with the world of oncology.
Many times we're the first one to see the patient for a diagnosis. We're the ones who perform biopsies many times, although radiologists can do the same thing in that regard. But mainly the surgical treatment, the taking out the tumor, the staging the tumor surgically. And obviously, as you actually said it very well, forming a part of this multidisciplinary team to streamline the patient to every individual patient.
And I'd love to, and I don't want to bring it up right away, but somewhere in the show, if I forget, let's talk about tumor board. Because I think that, I remember the first time I heard about that years ago, I thought, how great that everybody really has a whole set and team of doctors looking at their case to figure out how the treatment should be or what at least is presented to the patients. Dr. Gupta, we talk about this with almost any oncology, mainly I guess with prostate and breast, about the screening options and what over the last 20-ish years have been recommended. It's changed a little bit, but in general, the rule of thumb is what now in the world of breast cancer screening?
I think, Catherine, everyone agrees that breast cancer screening is important and that it saves lives, and that women who have mammograms every year have a much higher chance of survival than the women who don't. So I think every specialty involved in women's health does agree to that. However, over the last 20 years, and as he said, 22 years for this program, things have evolved. One size does not fit all. And so it is becoming much more important to individualize screening, even for the average risk population. So a discussion with your physician who knows you well as to when to start screening, because different specialties with the different societies have different recommendations for age to start screening. But broadly put, the American Cancer Society still recommends that screening be started at age 40 if women want it, but the discussion of risk and benefit should be there.
Right.
Not everyone at age 40 needs to have a mammogram.
Right.
After age 45 to 54, it should be annually, and beyond 54, at this point, the recommendation is every other year.
But and
that
is that
doesn't
every
mean
other year if there's been
risk.
no findings? Okay.
This is, yes,
Okay.
average risk, not a high-risk patient, and there are no findings of concern. Then it can be every other year. However, if a woman wants to have a mammogram every year, she should discuss it, and she can have it every year. There's nothing to say that you have to go every other year.
And crazy question, and I didn't ask you before the show, will insurances usually pick it up if you do want it every year, even after the age of 55 or 54?
Yes, they will.
That's important for the audience to know. So I'm just going to say get it every year. I mean, that's I started at age 38. And the reason why, and I don't want breast self-examination to be thrown off the table, and you and I said this too, and for men and women, just know your bodies. And even, I have a daughter who's 21, and even when I was 16, she's like, Mom, really? And I put the little shower card up and showed her what to do. Whether she does it or not, I don't know, but it's good to know, especially women who have fibrocystic breast disease or condition, just know where the lumps and the bumps are. And when those change, or if those change prior to the age of 40, then definitely go check it out. Would you agree with that?
I would totally agree with that. Every woman should know the landscape of her own breast and report any change.
Okay.
Whether it is size of the breast, change in contour, nipple retraction, anything that she feels that was not there before that happens should be reported.
And I do kind of want to talk a little bit about just women in general who get their annual exam, usually means a pap smear. I know with my doctor, when I get my annual exam, a breast exam comes with it. It's not requested, it's just like it's part of the deal. And I understand that's not always the case, but you could always request that as well. Is that right? Or how is that? Because you said that may have changed a little bit these days.
A breast exam as a recommendation that it needs to happen has changed, but I agree with you completely that when a woman goes for a pap smear, get your breasts checked. A lot of times when women examine their own breast, they're uncomfortable with what they're feeling. And so it's a really good time to discuss that with the person who's examining. Is this normal that I'm feeling? And they need reassurance. Also, I think over the years they become better at it.
Right.
Yeah,
exactly.
Of recognizing what should be reported or what should not be reported.
Okay. And just for people who might be a little bit younger, and if I remember this right, and correct me if I'm wrong, it's usually about a week after your period is a good time to do it, because usually sometimes things get tender or move around a little bit, but in general, the week after your period, a couple of days after your period, in the shower with soap, just get familiar with what is happening there. Dr. Herrera, I'd like to talk to you a little bit about just how treatments have changed over, and let's say the last decade. I remember when we first started doing shows on breast cancer, I feel like the course of treatment has been the surgeon would go in, do a biopsy, take out whatever he needed to take out, whether it was a lumpectomy, whether it was a mastectomy. Then the world of chemotherapy would come in, and then the world of radiation would come in. It's different with everyone, and I understand that. But the shift of why and how individual treatments started happening, I would love for you just to kind of take that anywhere you'd like to, because I feel like today, every woman that has breast cancer that I know is being treated so differently and successfully, often very successfully. Take that however you want to, and the two of you feel free to chime in on that too. It's a big one, I know.
It's a good question, but it's true because in the past 10 years, a lot of things have happened. I think we can start by saying that what we know as breast cancer is actually more than one disease. I think we can make today 3 large groups of breast cancer. And there is molecular differences. There is ways to diagnose them a little bit different also. Basically, we could say there is cancers who are more indolent, for lack of a better word, and cancers that are more aggressive. The management of those cancers vary. For instance, tumors that are very aggressive, in the biology is aggressive, sometimes are treated initially with chemotherapy. And this is important because, say a patient is talking to another and they say, well, they gave chemotherapy to me after I had the tumor taken out. That used to be the rule 10 years ago.
Right.
Right now, about between 20 and 25% of breast cancers can be given chemotherapy before the operation takes place.
And why is that? If we can explain to the people at home, are we trying to shrink the tumor a little bit so it's easier then for surgery, or maybe just explain physiologically why that's the case?
Well, there is more than one answer to that. The studies that gave chemotherapy initially before surgery where the primary focus was to see if tumors that were not rendered to be operable would become amenable to be operated on. We now use that also as a trial of we want to see if the chemotherapy is working, and this is a very good example in vivo to see if a treatment is actually being useful on the patient, because we have non-invasive ways to see how this tumor is behaving. Typically, the tumor would become smaller, and that can be assessed by clinical exam or non-invasive measures like ultrasound, typically. In the area of systemic treatments, it's not just chemotherapy. There is new agents that are called targeted agents. That's the other new advancement over the past 10 years. And I think the most important part of it is that more and more often this breast cancer is treated in a multidisciplinary fashion. So, and this is not just an academic point. It is, we know for sure that the outcomes are improved when a multidisciplinary team takes care of the patient. So I think the concept of the old cancer, I mean, the cancer doctor is an old term.
Right, yeah.
I don't think that there is a cancer doctor anymore. There is a cancer team composed of different specialists who approach the cancer in a separate fashion and yet complementary. We complement to one another. And I think this is really the reason why the outcomes are getting better.
Agreed,
on top of the whatever improvements in research and so on.
Yeah. And it's, if we don't, Dr. Landaudo, since you're the surgeon, you get to go in and see what all this stuff is. So I would love, if you don't mind, to take this model.
Can I add one thing to
You absolutely can,
comment?
yes. Sorry.
I think what he said, and touching on the point that targeted therapy is important nowadays, and it's actually a mainstay. It's called molecular profiling. What we're trying to find out is whether a tumor, how is the tumor going to behave?
Right.
If it has a higher chance of recurrence, especially the ones that have particular proteins. In fact, there's something called Oncotype DX, where they study a tumor with a 21 array of genes that we know for sure these are pathogenic. These actually are causes of cancer. And depending on the number of mutations of those genes, it could be a low recurrence. The tumor can be of low recurrence, intermediate recurrence, or high recurrence. And something very important that happened this last year is that in the past, in the last 2 or 3 years, the intermediate recurrence scores were sometimes treated. And recently...
So say that again, if you don't mind. So this year happened what? Just so I have it clear when I'm thinking about it.
This has been going on for a while.
Okay.
This test has been out on the market for several years. But in this last year, let's say the patients who have a low recurrence score,
right?
Those patients would not get chemotherapy for the most part.
Okay.
And only receive hormonal therapy.
And that was working better for those the patients.
Those patients, right. The intermediate ones have a little higher recurrence rate than the low recurrence rate. And those sometimes were treated in the past few years.
So you're really finding a whole different way of treating right now as well. And this is, goodness, I don't want to confuse the two, because I know that there's genetic testing, but that's not what we're talking about. They're completely not what we're talking about. So what we're talking about is once a female has been diagnosed with breast cancer, now we're going in to find out what type of breast cancer it is. So you as the biopsy guy, and how does one find that out? Is it through the biopsy? Is it through blood tests? Is it through a bunch of different type of tests? If you could...
Originally from the biopsy.
Okay.
You know what type of cancer it is? We look something called tumor markers. These are proteins within the cancer cell that tell us more or less how it behaves. Whether it responds to estrogen or progesterone. HER2 is another important one.
What is HER2? Because I hear that all the time. HER2 is...
It's actually a protein within the cell.
It's a type of protein.
Yes, it's a facilitator within a reaction.
Okay.
That by blocking it, by targeting that specific protein, we can stop a reaction and that way give a therapeutic benefit to a patient.
I see. Okay. Because I hear HER2 positive, HER2 negative. I feel like that's almost accompanied with diagnosis these days.
Our pathology colleagues have come a long ways. And we have prognostic markers, the estrogen receptor, progesterone receptor, and the HER2/neu.
Okay.
And that's what you're thinking of when the HER2/neu is overexpressed as a protein on the surface of that cell. Think of it as it's sending messages to the cell of dividing more rapidly. So the HER2/neu positive cancers are more aggressive.
I see.
If the markers are absent, a triple negative breast cancer, that is treated differently. That's what Dr. Harada was alluding to. Those are the patients that benefit from getting chemotherapy up front before Dr. Landeros goes in to remove it. So we can actually see whether the cancer responds to chemotherapy. And
this
we may
is
find
so
a complete
different
response.
than we started talking about this.
Yes.
So very, very different. And you're looking at me because I know you want to say something. So without me asking a question, what is it that you want to throw out there?
I wanted to repeat what
okay.
No, I was just going to say,
right now,
if people can just understand that the germline mutation is different, that's your genes. And so the BRCA1, BRCA2 are totally separate. What we are talking about is the genetic makeup of the tumor, not of the person.
Gotcha.
Which then leads to how do you treat it. And that's how that Oncotype DX recurrence score testing was developed.
Okay.
Which we can now look at 21 genes in that tumor cell and say, okay, the risk of recurrence is low. That's the patient Dr. Harada will treat with hormonal therapy. The intermediate risk patients were the ones that were studied in the trial Dr. Landeros is talking about, where before everybody was getting chemo. Now, if the risk recurrence is lower than 25, 26, that patient benefits more from hormonal therapy than chemo. So Dr. Harada can avoid chemo. The high-risk ones will get chemo still. And in his field, the exciting thing I see is immunotherapy. And
immunotherapy, that... I feel like every year we're going to have a little bit more to add. And then within 2 years, we should have an entire show just on immunotherapy.
And probably in 5 years, you won't see me here anymore because I won't be doing
surgery,
surgery anymore.
Well, you'll be doing surgery on something. You'll be replacing my knee. That's what you'll be doing. So let's talk a little bit about immunotherapy because I feel like we kind of introduce it but don't really go too far into it. There's a lot to be discovered still, but the exciting thing about it is, in your opinion, what would you say?
Well, it's another good question.
Yeah, and it's a whole hour show, and I respect that it could be.
But I think, let me summarize saying, I think the treatment of cancer is heading on the right way. And the reason for that is cancer is basically a defect of the immune system. The immune system is the system that preserves our own identity. Let me give you an example, Catherine. When we get an infection, whether it's by a virus or a bacteria, our body reacts in response to that foreign substance. It's typically a foreign protein or a foreign microorganism. The same thing happens when somebody receives a transplant from another person, whether there is a bone marrow transplant or a solid organ like a liver or a kidney. Remember, patients who receive an organ, we have to give a drug called immunomodulators. So, for the first time, and actually Dr. James Allison from MD Anderson was one of the 2 Nobel Prize winners this year. He was a pioneer in the immune modulation of cancers. So that's why cancers, and this is an important concept because I've heard people, well, can I get cancer by being with somebody else who has cancer? No. Cancer is not contagious because it's a defect that one has that allows the immune system to lower the guard, and so cancer appears.
That's an interesting way of saying of lowering the guard so the cancer appears. Right. Sorry. I just love the different ways of looking at this. Okay.
If you ask me, okay, why it hasn't been, why we didn't know more about these things? Well, the immune system is a very difficult organ to harness. It's very delicate. So for the first time, we have medications that, and I want to give you the example, rather than potentiating or regaining full power to the immune system, we're just pushing them very softly, so enough to kill the cancer, but not to cause severe reactions. This is very important because in the treatment, not so much in breast cancer, but in other solid tumors, there has been very old studies from the early 90s, pioneered by Dr. Rosenberg in the National Cancer Institute. They were given a substance called interleukin-2, which is a direct stimulating factor in the immune system. And those patients had to be treated in the intensive care unit. And still, people could die from complications.
Wow.
If you fast forward another 25 years, where we are today, we have these medications, and this the scenery of cancer is changed completely. I think the way, and this is actually the way to treat cancer, not just breast cancer. So I tell my patients normally, stay tuned, because when we hear about new breakthroughs in breast cancer are happening in that area, in the harnessing of the immune system.
And the immune system in and of itself, such a complex system in and of itself. I do want to remind our audience that if you want to call in live with some of your questions, the number is 881-0013. We are also streaming live on Facebook. So if you're watching this on your phone, which a lot of people do nowadays, I guess, you can open up Facebook and you can ask questions via Facebook too. Just put on the El Paso Physician, KCOS TV, the El Paso Physician. Questions here. I'm going to go to the 3D mammogram really quick because we are talking about prevention, if we can get, so everything in treatment is so much better if we can get something early. So I really quickly want to talk about the 3D mammograms. I think about 10 years ago, it was like, hey, everybody ask for the digital mammogram, and that was the new thing. And now it's like, hey, ask for the 3D mammogram, and that's a new thing. And Dr. Gupta, as I know you're a radiation oncologist, but you are also able to really see images, and when you're targeting for radiation therapy, such targeted images, but why, what is it about the 3D image that is so much better than the 2D image?
So if you think of the 2D mammography, which is the digital mammography, the breast is imaged in 2 dimensions. So I should describe it. The breast is placed on a plate, and then the x-rays are done to give the imaging from top, bottom, and then side to side. Those are our 2 images.
Okay.
So the radiologist gets these 2 images and he's looking at it as 2-dimensional, and we know breast is not 2-dimensional. It's got 3 dimensions to it.
Right.
For 3D mammography, multiple images are done in an arc fashion of that breast, and then the smart computer reconstructs it in a 3D model. So if you think of what Dr. Landeros has there, then you can actually see better. If this was a flat pancake, you would only see 2 areas, right? But in 3D modeling,
Point it at
then,
that camera right there.
then you can see much more detail. So it is beneficial when the breast is very dense. Also, there are lesser recalls because the mammographer is able to see much better. So if you think of it as a forest that's dense, it gives a much better detail in that forest.
Right, exactly.
Yeah.
And the other name for it is tomosynthesis.
Tomosynthesis.
It's because
okay.
they cut the breast in 16 different cuts. So that adds a little bit more radiation. I imagine that's, in the future, that's where the debate is going to be, where that's going to be not a problem and not an issue, and this can become a screening tool.
Actually, the imaging is being developed where hopefully the dose of radiation will be as much as the regular digital mammography.
Nice.
So that is happening. In fact, there is a machine that does 3D tomo where it is almost equivalent. Because we talk about screening, and we know even though we see much better with the 3D, it's not a screening tool quite yet.
Exactly. We think it's the thing of the future.
It's going to happen.
And it's going to happen eventually.
So it's not a screening tool just yet, but when women go in, I think the last
you can
one I
ask
did.
for it.
Okay, because the last one I did was a 3D mammogram. So is it? So when you say it's not a screening tool, help me understand.
Not for the masses.
I see.
Remember, the screening is for general population, average risk, no symptoms, not worried about a whole lot, but wanting to see every year if there's a change.
Okay.
So as in the screening, as a screening tool, the recommendation is still not there.
Okay.
But you can certainly ask for it as a screening tool.
Right, right.
And insurances do cover it.
And they do, and that's nice too. I'd like to, if we could, because we haven't had a breast model before, and I feel like it's nice to be able to go through. I don't know if it's helpful to take this off or not. I think I'm going to take this guy off.
Should I pass it off to Dr. Landeros?
Yeah, Dr. Landeros, it's your turn to talk, sir. So if we can explain, with a biopsy, with screening and also with the biopsy, it'll be the camera that's closest to me. That will be the one that's focusing on the breast. And if you can explain, like show the inside to the... You can put it on top of the book, actually. That might be good.
Maybe here.
Okay. Oh, my flowers. I was trying to decorate the table today. The pumpkin's still there. It's good. So explain the different layers that we're looking at in the breast. And you've got some tumors in there. You've got ducts in there, etc. If you can kind of... Yes, you may.
Well, remember that the breast is a modified sweat gland. Okay.
A modified sweat gland. Now, I have never heard it be that
it's
before.
It's part of the skin and integument system.
Right, okay.
It is located in the chest, obviously, above the rib cage. This is the layers from bottom to the top. we're looking at these little ovoid structures, are the cross-section of the ribs. These are intercostal muscles, part of the chest wall. Over that, we have the muscles, the pectoralis muscles. You know, there's a pectoralis major and minor that are located in a layer over the chest wall.
Men like having big pecs. You can say that on the air so we can understand that.
Yes, unfortunately, some of us can have a hard time without them. Anyway, so after that comes a gland.
Right. Okay.
There is it's called a thin layer of fat called retromammary fat, dividing the space where the actual breast is and the chest wall. Eventually comes a gland. The breast is composed of glands producing milk. This milk has to be transported towards the nipple through ducts.
Right.
In fact, not the great majority, but 3/4 of the breast cancer is from ductal origin.
Okay.
Okay. So eventually the milk is transported and empties through the nipple. The issue here is that within the breast tissue could be multiple things. And starting with fibrocystic breast disease is composed of cysts. These are sort of globules filled with fluid, water. And this is sort of an example. These are 2 examples of it. On this side, we have what's called the fibroadenoma, which is a solid mass.
Okay.
Also benign. These are 2 benign structures. Eventually,
and couple that, if you don't mind, because people hear about fibrocystic breast.
That's correct.
Disease. I think it's condition. I don't think we
it
call
used
it
to be
disease,
called
right?
disease several years ago, and it's so prevalent that we call it condition.
Okay. And so, if you don't mind, show again what you're looking at with the
This is a
fibrosis
fibroadenoma
right
here, and
Okay.
this is a cross section of it. But usually, it's sort of glistening white, and these other white structures here in this model are cysts. They're actually a enclosure of fluid.
Okay.
So
they're cysts, not tumors. And there's another. There's that other question.
Right.
What is a cyst and what is a tumor? I know when I was younger, I had an aspiration. Thankfully, it was a cyst. It was fluid-filled. Life was good. I was very happy.
Usually
but it still
tumors
scares
are referred to as solid masses. It could be a benign tumor or a malignant tumor. Tumor not necessarily means cancer.
And
but
cysts are completely different. So when you hear the word cysts, it's not really cause for alarm because people, you know.
In general.
There's
a few cysts that can be.
Okay.
But in general.
Gotcha.
So this is where the cancer breast starts. It could be usually from the ducts. It can be from other origins, but mainly from the ducts. From the ducts, it starts within the duct itself. And as it progresses and go through the basal membrane of that duct and invade the surrounding parenchyma or tissue. Once it invades that tissue, it can be, that is where the lymphatic system, part of our immune system, picks up those cancer cells and usually presents them to the lymph nodes, which is the first echelon of our immune system to combat cancer. If it gets to the lymph nodes become large. They start producing, our immune system starts producing cells to try to combat these, but they're not very effective as it is on their own.
Is the sentinel node a node that you can see on that breast model, or maybe we can talk about the sentinel node and why that is so important?
Let's say this is the left breast of a patient. It's sitting like this, and here's the arm coming off the body. Right here in the axilla, we have the axillary lymph nodes. That would be commonly the first place where cancer reaches.
Okay.
Outside of the breast.
Okay, interesting.
Okay. The sentinel lymph node is a procedure that we tend to do many years ago. I'm talking about more than 20 now. That we used to remove all the lymph nodes and cause complications like swelling, and they call it lymphedema. That was very common to see. Now we still see it, but not as often. The reason for that is because procedures like the sentinel lymph node have been more common use. And that it means injecting a dye could be, and usually it's a combination of a radionuclide dye and a colored dye. And the area around, it could be around the nipple, it could be around the tumor. But essentially, this is what I do in my practice. We inject it around the areola. It picks up by the lymphatics and reaches those first 1 or 2 lymph nodes here in the armpit. That, because of proximity, because it being a straight line with the breast tissue, can be the ones more prone or more at risk to develop metastases. And those are the lymph nodes we normally remove to study in a microscope.
Beautifully explained. And the Sentinel is something that I failed to ask about that during the last time we had one of these shows. I know that time is ticking away. I've got a couple of questions here from the audience. And targeted therapy, I have on 2 different pieces of paper here. So I don't know if that's a new way of saying, I think a targeted therapy is radiation, but I could be wrong.
Targeted therapy, I think what they are referring to is what Dr. Harada does.
Okay.
Say for a HER2 positive patient, Herceptin and Perjeta are drugs that actually go block the receptor. And he can elaborate on how that works and when it is used.
Yeah, targeted therapy refers to the systemic, typically intravenous treatment that is given by drugs who are sort of like man-made, so to speak. They are called targeted therapy because they are designed drugs that are targeted specifically to very specific receptors on the cell.
Okay.
Remember, when a cancer cell has a receptor, it's kind of the receptor is the key of the gate. So if that receptor is stimulated, it will create a number of chemical reactions that will lead to the division of that cell. And cancer, remember, is uncontrolled division. It's uncontrolled duplication, uncontrolled multiplication of cells. So if somehow you can destroy or cover up the receptor, you are avoiding those cancer cells to divide.
From duplicating, yeah.
The first targeted therapy, although it was never called like that, was the anti-estrogen therapy developed more than 40 years ago. But the concept is the same. We have zones in the cell, in the cancer cells, that can be blocked. In doing so, we prevent the cancer cell to divide. These new drugs are designed specifically for those receptors, so to a specific target, and hence the name of targeted therapy. But conceptually, it works different from chemotherapy.
Right.
Chemotherapy essentially kills the cell. I mean, it kills all comers. The targeted therapy is smart weapons. It only goes where it is required and protects, for the most part, the rest of the body.
And that's, again, what's so beautiful about this team approach. So if you have cancers that are known not to be repetitive cancers, you can avoid the chemotherapy. Like you said, it kills everything in the body. I remember, Dr. Gupta, and I'm going back to a show last year, and I don't remember what type of radiation it was called, but I remember you talking about when you were applying or directing radiation to a very specific spot in the breast, that literally the patient would hold her breath, breathe in, and then there would be a very specific beam to a very specific spot, and it just fascinated me at that point too. What were you talking about, and has that changed at all?
I think we were doing the lung cancer show.
I think we were. You're
yes.
right.
And I was talking about stereotactic body radiation therapy for lung cancer, where small tumors could be very precisely targeted by high-dose radiation therapy that's given over 3 or 5 days. And you do respiratory gating because the lung moves, the cancer moves, and so the beam is turned on only when the cancer is in that beam. And then you modulate the patient's breathing. That's what you're thinking of.
It's still cool, even though we're doing a breast cancer show.
But
cool. Again, it's just, again, that idea of what's on the forefront with every type of treatment that we're doing. I want to go back to biopsies really quick, because when we had that breast model, I would love for you to explain to many women who have not had breast cancer but have had some kind of a false positive on a mammogram, have gone in, and I'll just give myself as an example. When I was younger, in my 30s, I had a couple of cysts. They were aspirated. But to me, they were scary because they were cysts on my breast. And then in my mid-40s, I just had a dimple in my breast. I had a mammogram, and I had calcification. So I had microcalcifications. Again, very different. That's definitely a milk duct type of a thing. But as a doctor who biopsies, who has to figure out how to diagnose, give some case studies, if you would, of just different types, common cancers, but also microcalcifications aren't very common. Just in general, what you see as the person that usually diagnoses from a physicality point.
You mean
versus,
how to perform a biopsy?
Yeah, I guess let's talk about an aspiration and a biopsy, the differences there.
Two main ways of performing a biopsy on a new breast finding. One is called the fine needle aspiration, which is not very much used. Now I use it only for cysts.
Okay.
And the reason for that is because it doesn't offer much information. The amount of tissue that you remove with a fine needle is not as much as you would have when you use what's called a core needle, a larger gauge needle that enters and retrieves a portion of the tissue to specifically look for those receptors we were just talking about.
Right.
So that's the information we need before we go into any type of treatment on a cancer. Those are two needles. We use local anesthesia. We numb up the skin. We can, for example, calcifications are not felt or seen by the naked eye, are only seen on mammogram. So we ask the radiologist to perform what's called a stereotactic needle biopsy. They have a mammogram machine connected to a computer. So the patient is undergoing a mammogram. The computer dictates the coordinates where the needle needs to go to retrieve those calcifications.
That was no fun, I gotta tell you. Anyway, yeah, but necessary
Yes,
and good.
yes.
Undergo it. I shouldn't have said that out loud.
If you need it,
But
undergo it.
If
yes.
you need it, undergo it. Absolutely.
That's right.
Yeah, and I like the way that was explained too, because, and then let's talk, since you're talking already, let's talk about a lumpectomy.
Right.
So you're going in, and this is a cancer that is contained, that is not metastasized. It's in a spot. Explain a lumpectomy, and explain then what a mastectomy is.
Okay. Depending on the size of the tumor compared to the size of the breast, a lot of time, or the location of tumor, would dictate the type of procedure we can do. In some occasions, we can ask Dr. Rad to help me out and to give chemotherapy before the surgery to shrink a tumor the size, if it is responsive. Not all tumors are responsive.
Good point.
If it has the receptors that tells us that it will be responsive to this type of treatment, to use that treatment to shrink it and eventually perform what's called lumpectomy. Lumpectomy.
I'm going to interrupt just because I have a question there.
Sure.
How long does it usually take to find out if it's responsive or not, if that tumor is responsive?
Yes, the actual diagnosis of cancer comes back in less than 48 hours.
Oh, goodness.
The receptors that we're talking about, the estrogen, progesterone, HER2, take about a week, usually 6-7 days.
That makes sense. Okay, gotcha. I didn't mean to stop you, but I thought while that question was in my head. Okay, so now we're trying to figure out, so from there, if we're able to shrink the tumor a little bit.
Or if the tumor is small enough where you can perform a lumpectomy without deforming the breast significantly. That's what my recommendation would be. Now you have to put into consideration also the history of the patient, the family history, the genetics. If it's a young patient and she's undergoing genetic testing, if she has a positive result, or there's a genetic mutation that is highly pathogenic, then we may consider doing a mastectomy right off the bat. So all these little things, caveats you have to consider before you offer type of procedure. Lumpectomy is making an incision, removing the mass with a little rim of margin surrounding it. Many years ago, we talked about margins.
Right, in fact, I was going to just ask you about that, right.
The greater the margin, the less recurrence rate, and so you have to strive for the greater margin. Well, there's a lot of deformity with that.
Yeah.
Nowadays, and this has been proven over the past few years also, that you only have, in an invasive cancer, you only have to have a negative margin. Doesn't matter by how much.
So when you say negative margin, what do you mean by that? So it's not a measurable margin?
What I mean is that if the pathologists normally stain the tissue that we give them,
I see.
all around.
Okay.
And they cut it. If there's no tumor on the ink, if there's no cancer on that ink, that means a negative margin.
I see. I see.
Okay, so it could be 1 millimeter, it could be very fine. We can tolerate that with the help of Dr. Gupta and Dr. Rada.
Yeah, I am thinking about the old days. I'm thinking about just the skin cancer that I've had removed. You know, it was a mole, and then it's a scar this big. You know, they had to get the margin. So yeah, it's interesting when you put it in that way. We haven't talked about risk factors, and we haven't talked about male breast cancer. and I'm getting the countdown little by little. So I'd like to talk about risk factors, because it's basically being a woman getting older. But on that note, because I'm 51, I haven't entered menopause yet, but it's around the corner, I know. We talked an awful lot years ago about hormone replacement therapy with breast cancer. I feel like I'm not hearing a lot of that anymore. I don't know. Maybe it's just because I focused on it years ago. Is that still something that's a thing? That's a big thing, a little thing, or has there been more research in that area?
It's still a thing.
It's still a thing. Okay.
The hormone replacement therapy for a prolonged period of time increases the risk of breast cancer.
Okay.
So that question did get settled.
Okay.
And so for a year, 2 years, if a woman is going through menopause and has terrible symptoms, there are other drugs that you could use now. Before it was just had to put a woman on estrogen.
Okay.
But if in a younger woman, for some reason, you have to do replacement, it can be done. And it should be done. For a few years, I don't think it matters, but years and years and years, 10, 15, 20 years, like we used to leave women before, that is no longer being done.
Now let's talk about that and the difference between birth control and then hormone replacement therapy. Because birth control is hormones, but it's not the hormone replacement therapy that women that are going into menopause are receiving. Because I usually get one of the two questions, because women who are on birth control could be on birth control for 2 decades, and then they're going through menopause, they don't feel, and then it's a different type of hormone. Maybe you can talk about the 2 different types of hormones, and does birth control pose any kind of a risk for breast cancer down the line? Do we even know, or is it just the replacement hormones?
I think most studies show that using oral contraceptives, for most women will use them for 10 years and much more in the younger years, probably does not increase the risk. But as a woman ages, your breast cancer risk has increased anyway. Right? It is one of the risk factors, being a woman and being older, as you said. And leaving an older woman on estrogen for a long period of time seems to increase the risk.
Okay.
And why do women get breast cancer even if the ovaries have been removed? So,
excellent question, right?
We still store estrogen in our fat. We still convert some there.
We don't have fat. What are you talking about? Dr. Harada, you're a man. Let's talk about male breast cancer. So it's not common, but it does happen. And the last time I kind of looked, we have 2 to 3 cases a year, más y menos, in El Paso. We talk a lot about women. We talk about breast cancer screening in women. Men don't know to look for breast cancer. But in general, say whatever it is that you think you should say, because you're on TV and people are listening to you. What about men and breast cancer?
I think it can be summarized. First of all, 1% of breast cancer happens in men. So we are not off the hook, number one. However, because it's only 1%, there is no need for men to undergo the screening procedures that women require. This is the first thing. The second thing is, if there is a case of male breast cancer in the family, that is a red flag. And every single man who develops breast cancer needs automatically genetic testing, meaning this person can harbor mutations that can be transmitted to their offspring and create breast cancer, not so much in the boys, but in the girls. If that person harbors a pathogenic mutation like BRCA1, BRCA2.
Right.
So that's probably the most important thing. The third part would be is obesity is a major risk factor, and age.
And it's physically easier to see on some men than others if there's breast tissue, and I understand that is a little bit of a risk factor as well. Is that, and maybe it's obesity. I don't remember. I just remember seeing this on a breast cancer. It was a national show a couple of years back. We are at like the 8-minute mark. And so what I'd like to do is stop all questions for a couple of minutes and see what it is that we have not yet focused on tonight. This hour goes by so fast because there's so much to talk about. And Dr. Landaros, I'm going to start with you because you are the last one to talk.
Okay.
So what is it that we want to talk about tonight that we may not have talked about yet, or something that we'd like to touch more on?
Well, the fact we've done, as you said, you have this program for 22 years now, every October. Every month of the year is breast cancer month.
Exactly.
Not only focus on October. Take this home, take this information home, consult with your primary physician, have an examination yearly. These are things that can prevent a progression or catch things when they're small if somebody's to develop a problem like this. Surgery in general is part of the targeted realm, and where we try to minimize the amount of tissue we remove. There's techniques nowadays that we use to. It's called a hidden scar technique. It's part of marketing, I think, but also in certain occasions it's good to use, where you hide the incision right next to the areola, where it doesn't make much of a difference in the skin, or you can use the axilla to approach certain axillary tail tumors in the breast. Those are ways to avoid a scar, for example. They still need radiation therapy, and many will need hormonal or chemotherapy, but at least you try to minimize the scarring that way. I think it'll maybe come a day in many years from now, probably, that the surgery role is going to be less and less and less and less. What I would say about 10 years ago, what percentage of patients, Juan, would you see to treat medically first, chemotherapy first, and then surgery?
I think it was a very small minority. It was less than 5%, and over the past 10 years, I think it has quadrupled in frequency.
Yeah, I was going to say, when we first started this show, and Dr. Gupta was one of my very first, Dr. Gupta, Dr. Portillo, and I remember surgery was always the first line. It was just like, and I remember a show where I was like, no, you're wrong. You don't do chemo first, you do surgery. And we even had that discussion. And I remember, wow, what has changed in that world? So again, next year, this is going to be yet another very different conversation. Immunotherapy, too, is going to be, gosh, I feel like something I'm reading new about that every single month with different.
One thing you touched on early is the point of view of a breast cancer tumor board.
Oh, yes.
Presenting cases at a tumor board is asking opinions from experts. These usually are attended by other surgeons or other medical oncologists and radiation oncologists who give their opinion. And usually a patient would have more information to digest and to help make a decision with. So I think it's important to remember that if you're in any way associated with a breast cancer tumor board, you may have more of an option to make a decision, more information to make a decision.
Yeah, and that's always not tricky, but there's so much information out there now that the patient can consume that sometimes it's difficult to know what's real and what's not real. And with that note, since we're not running out of time, but there's a couple of, the National Cancer Institute, there is the number 1-800, the number 4, and then spell out cancer. If you have a phone that spells that out, I should get those numbers out there. But again, National Cancer Institute, 1-800-4, and then the word cancer. The American Cancer Society, and these are live people that talk to you. That's why I like to give out the telephone numbers. 1-800-ACS for American Cancer Society, and then 2345. Also, it's www.cancer.org. Also, I do a lot of research on WebMD, just WEBMD, and you can go into the areas there. And the reason I give those websites is those are peer-reviewed medical sites. Sometimes you can get stuck on a site that just has opinions and, oh, this is what happened to me and that's what happened to me. You want to stay away from those. Dr. Herrera, is there anything that we haven't talked about that you'd like to talk about this evening?
No, but I want to emphasize again what Dr. Gupta was mentioning at the beginning of the program. As important as it is, the approach we take from all the specialists, new therapies, new surgical techniques, and so on, everything starts with the patient himself. So common sense is not replaceable here. You have to know your body, And if there is something that just doesn't make a lot of sense, you need to ask for help. I think we cannot stress that enough.
Agreed. And you just know your body, boy, girl. Again, I have I have a 16-year-old boy, and he's got the testicular chart in his shower too. Mom! But it's in there. I know it stays in there. Dr. Gupta, how about you? Anything you want to talk about before we wind up?
I know there's a lot of controversy about age of mammography. It's pretty contentious. But I think every woman should talk to her primary care doctor and discuss the pros and cons of it. And my thought is get your mammogram done and never ignore a lump in the breast.
Exactly. Or a dimple in the breast. You
any
know,
change.
If it's something mine was dimple. Mine was like, why is that moving in? Very much agreed. I want to give a little bit of information. This doesn't have anything to do with breast cancer, but in general, there is a free tourniquet training that's going to be happening soon. And so I wanted to give a shout out to the medical students. There is a program that learn how to stop a bad bleed. What is a bad bleed? Anything that a Band-Aid will not take care of. And that is going to be with the Texas Tech medical students on November the 3rd out at the Fountains of Farah. And it's going to be from 8 o'clock to 2 o'clock. And again, just go out there. It's actually the first Lone Star Survival Texas tourniquet training. And we like to let people know also if there's CPR trainings. It's just nice to know this stuff because you never know if somebody's in an accident or that kid with the scooter runs into your car or something. So again, November the 3rd, Fountains at Farah, 8 o'clock to 2 o'clock, the first annual Lone Star Survival Texas Tourniquet Training community event. And I also want to say this program you'll be able to watch again on Facebook. You can look at El Paso Physicians and or you can look at KCOS TV, but you can also go to kcostv.org in about a day and then go to watch and then programs, local programs. You'll get to see this show completely from the beginning, and you'll also get to see an archive of programs. They usually go back about 6 months. So if there is a topic that was discussed over the last several months that you are interested in, you can go back and watch that as well. The same thing goes with the El Paso County Medical Society. Their website is epcms.com, not .org, so epcms.com. And again, look for the El Paso Physician logo on there. I want to say thank you again to James Fong. You did a great job. Will you come back?
Yes.
He is a medical student, year 2. You can wave. Everybody at home is looking at you right now, so don't pick your nose. And James is second year, and we also have Yuan Deng, who is her first year, but she's been here a couple of times, and it's really nice to get their questions, so it's always nice to see the friendly face that you guys are looking at when you call in. Again, this has been current updates in breast cancer. We have a couple of shows in November. Once again, we used to do this just once a month, and it seems like people just want to know all kinds of information. So we're doing 2 shows in November, 2 in December. You've been watching the El Paso Physician. I hope you enjoy this entire holiday season. Happy Boo Halloween coming up in a couple of days, Thanksgiving and Christmas. We'll see you soon. Good night.
Flour and mixed it with water and mashed it together till it seemed noodle-like, and I boiled some water and I threw it in, and sure enough, they did not fall apart. They ended up being a very delicious bowl of noodles.
So you kept working with the flour. Somehow you had this idea that if you put more flour into the water, it'll become like a dough-like thing.
Yeah, I had seen noodles made before, and I'd seen, like, my grandmother had made dumpling sheets, which are, I guess, flat noodles. So I had some sense of what went into them, but I didn't really understand, like, conceptually why when you add more water at one phase, they fall apart into a gooey mess.